Let's hope I don't have to do an invitation.
Good afternoon, everyone.
Good afternoon.
So wonderful to see you, Congresswoman, as always.
Thank you. Good to see you.
Hi, Jackie, Dr. Neal, good to see you.
Hi, everybody.
Hey there.
I think are we waiting for one more? Oh, there's Juan Pablo. Wonderful. I think we have our full panel with us, so we'll go ahead and get started. Given the time, I know there's a lot of panels during the summit, and we've been instructed to keep strictly to our time here, so we will definitely just jump right in. Good afternoon, everyone. Welcome to EHI's Virtual Digital Health Equity Summit. My name is Miele Adams. I'm Managing Director of Government and External Affairs at Philips, a global healthcare technology company. And I'll be your moderator for our panel. This panel is entitled Delivering Maternal Health Equity Through Telehealth and Digital Tools. We have a fantastic list of panelists for the conversation, starting with opening remarks from the remarkable Congresswoman Robin Kelly, who has been a stalwart champion for maternal health issues. We also have on our panel Juan Pablo Segura, who is the co-founder and president of Babyscripts. With us also is Neil Shah, who is the Chief Medical Officer at Maven Clinic. And last and definitely not least, we have Jackie Cornell, who is the Senior Director of Regulatory and Government Affairs at Unite Us. I think, to just get us started, I wanted to highlight for everyone, and if you are involved in health disparities work or working on maternal issues, you know that we are in a maternal health crisis, right? For women of color and women in underserved areas in particular, it's a matter of life and death. And when you think about women in rural areas, we have nearly 1 in 5 Americans that are living in rural areas. We have 7 million women that are living in maternal deserts. These are areas where there is little, very little, or no access to maternal care. And so it's really, really important as we think about how we deliver healthcare to this population, about meeting patients where they are, right? Extending care delivery to everybody, no matter where they live or work. That's how we reach people that need it the most. Most of the communities who reside, especially in rural areas, for example, are, including active duty members or veterans or American Indians or Native Alaskans, people that are receiving Medicaid and Medicare benefits, experience, I think, twice as many deaths due to COVID, for example, as there are their city dwelling neighbors, right? And so it's really important for us to respond to this disparity, to respond to this need. And telehealth can really facilitate, care access, care delivery. We want to facilitate people getting regular checkups. We want to facilitate remote monitoring for mothers. We want to help people manage their chronic illnesses, which are oftentimes the underlying causes for really poor maternal health outcomes, right? Especially when it comes to the disparities that we see. We really want to support telehealth as we see it, now and in the future, massively accelerating and improving care outcomes for all of us, especially those in underserved communities. And Philips has been doing a lot of work in this space. We've been working really hard to connect rural communities to quality care, relying on innovative technology and portability. One example is Philips Lumify, which is a point of care ultrasound, and it it really helps providers to take high quality ultrasound almost anywhere. And this helps them to evaluate and manage patients in respiratory distress, which is a crucial tool, particularly over the last year and a half, during the COVID pandemic, but, beyond that. Most recently, Philips has a partnership that we started with the UCSF Health Equity Action and Leadership Initiative in Navajo Nation, where we're offering our point of care ultrasound training to local fellows at the reservations. And the project has two primary goals, right? To train providers for independent use of point of care ultrasound and to give providers the tools that they need to train and provide access to care for their communities. This training model, I think, is really crucial to ensuring that we continue to provide access for the Navajo Nation, even as we see barriers in connectivity, broadband, which is an area that, Congresswoman, I know you've been working on very much so, travel, barriers, allowing community members to be cared for by their providers and know that they know and they trust, right? But to be closer to home. I think it's so important that as we are working through our solutions as, people in the space that are entrusted to provide medical devices, to provide care to patients, that we are thinking through also how to best meet people where they are, how to address needs and not expect, changes that are beyond a person's situation, right? So I am pleased now to just introduce Congresswoman Robin Kelly, who has been doing amazing work to bring care to folks in underserved communities, amazing work to break down barriers, amazing work to promote telehealth and broadband. The Congresswoman will provide some remarks here with us. I know you have a busy schedule, especially this week. But since being elected to serve the 2nd District of Illinois in 2013, Congresswoman Kelly has worked to expand economic opportunity and community wellness and public safety across her state and in the nation, championing numerous initiatives to generate job growth and reduce health disparities. Congresswoman Kelly is also Vice Chair of the House Energy and Commerce Committee, which is the main policy writing body for the House. She serves on the Health, Energy, and Consumer Protection and Commerce subcommittees. Her commerce work is focused on expanding access to healthcare, consumer protection for families, and economic development. She's been committed to improving health and wellness of vulnerable communities across the country. She also serves as chair of the Congressional Black Caucus Health Braintrust. She co-chairs the Congressional Caucus on Black Women and Girls. She also co-chairs the House Democratic Policy Group and House Tech Accountability Caucus. Prior to her election in Congress, she was a member of the Illinois House of Representatives and served as Chief Administrative Officer of Cook County, the 2nd largest county in the US. So just a very impressive background, very impressive work that you're doing, Congresswoman. We appreciate you taking the time to talk with us, and I'll pass it on to you. Thank you again.
Thank you so very much. It's an honor for me to be with you this afternoon. So good afternoon, everyone, and welcome to eHealth Initiative's Digital Health Equity Summit. I'm excited to be with so many providers and patients, administrators, technology experts, and public health practitioners that are gathered here today to learn about how maternal telemedicine practices and digital tools have been used during the COVID-19 emergency health crisis. You've heard all my titles in Congress. I don't think she missed one, but I also speak to you today as a mother of two, a stepmother, and a grandmother. I have leveraged my position in Congress and drawn from my experience as a mother to mobilize my colleagues to address health inequities, most notably the maternal mortality crisis. Despite spending 17% of our GDP on healthcare, the rate of maternal mortality in the United States is higher than that of any other developed country. Until the maternal mortality issue stops claiming the lives of birthing people, I will continue to remind everyone that each year, 700 Americans die from childbirth and pregnancy-related causes. Many of these deaths are preventable, and they often occur between 43 and 365 days postpartum. While we have seen many major advancements in healthcare over the last few decades, women of color and women living in rural communities continue to suffer the most. Across the country, more than 50% of rural women live more than a 30-minute drive away from the nearest hospital offering perinatal services. Black Americans make up 8% of the rural population and 40% of the 5.2 million people who identify as Indigenous live in rural areas on and off tribal lands. The shameful result of reduced access to care, among other factors, is that Black and Indigenous women die from pregnancy-related complications at 3 times and 2 times the rate of their non-Hispanic white counterparts, respectively. The COVID-19 pandemic required us to use telemedicine to minimize patients' exposure to the virus while continuing to provide much needed care. This allowed pregnant and postpartum individuals who face geographical and socioeconomic and various other barriers to care to stay connected to their healthcare team. New and expecting mothers use telemedicine to submit weekly blood pressure readings and weights to the electronic health record using smartphones. Providers employed solutions at the intersection of maternal and behavioral health, such as MCPAP for moms to provide real-time perinatal psychiatric consultations and resources for referrals to effectively prevent, identify, and manage pregnant and postpartum patients' mental health and substance use issues. As we continue to modernize and make use of digital medical tools to address maternal health concerns beyond the COVID-19 pandemic, it is so important that we ensure these tools are being developed for and made available to the individuals who need it most. In Congress, I have championed policies in the Mamas Act that center health equity, improve data collection, extend Medicaid coverage for new moms, and encourage increased education around how racism, stigma, and bias show up in healthcare. However, the Mamas Act was developed in 2018, long before the COVID-19 pandemic. While the policies in that bill need to become law to improve the lives of pregnant women and new moms, we have to also work to ensure that digital health tools that have become more popular during the pandemic remain accessible to everyone. To help in this effort, I have called for improving the availability of broadband so that patients living in rural areas with limited access to internet connection do not have to forego critical health services. I have also introduced the Evaluating Disparities in Outcomes in Telehealth Act to make sure policymakers have the data necessary to design equitable telehealth policies. This bill will require the Secretary of HHS to study the impact of telehealth on utilization, costs, fraud, privacy, and equitable access within the Medicare and Medicaid programs during the COVID-19 emergency. The study would also include a summary of telehealth utilization data, such as the number of telehealth visits, whether they were audio only or in-person visits, disaggregated by service type and demographic characteristics. A study like this would ensure that innovators and entrepreneurs, such as the talented individuals we have on today's panel, would have the information they need to continue to develop the tools we need to address the maternal health crisis, among other major health issues. Thank you so much again for the opportunity to speak to you today, and I look forward to collaborating with all of you to eliminate the maternal mortality crisis. Thank you so much.
Thank you so much, Congresswoman Kelly. I think with you as a champion of this issue, I see success around the corner. Those are fantastic bills that you're working on, and Phillips, and I think a lot of us on this call are all behind you 100% to help promote and push it through. So thank you again for everything you're doing.
Thank you.
Thanks for joining us. I know the Congresswoman has to leave us, unfortunately. Being a member of Congress, there are bills to vote on, and she's got bills on the floor right now. So we'll move forward with the rest of our panel. We have Dr. Neil Shah, who is Chief Medical Officer for Maven Clinic. Dr. Shah, I'll invite you to introduce yourself and say a few words about the work that you've been engaged in.
Sure. Of course, Congresswoman Kelly is a hard act to follow. As you said, um, uh, she is remarkable, and the work that she's doing is remarkable. And this summit and this discussion really comes on the heels of so much activity in Congress right now, including the Build Back Better Act, which, regardless of what happens in the Senate, will probably be a multi-trillion-dollar infrastructure bill, $5 billion of which is for this very issue, for maternal health equity. By way of introduction, I'm an obstetrician, so I take care of people who are pregnant. I'm also the chief medical officer of Maven Clinic, which is the largest virtual clinic for women and families. And prior to that, I was a professor at Harvard Medical School, where I did research on the maternal health crisis and was among the group of people who pointed out that an American today is 50% more likely to die today than her own mother was. And that really the only explanation for that, to put it directly, is racism, because if you're Black in our country, you're 3 to 4 times more likely to die. And when we talk about maternal health equity, and really the promise of digital health, I think it's really important to note that there are multiple intersecting inequities that I think the Congresswoman spoke to very well. It's an issue of gender equity. It's an issue of racial equity. It's an issue of geographic equity when we think about what's happening in rural America and the promise of digital health, or even urban underserved areas within Boston. Where I practice, if you live in Dorchester, you have to take 3 buses to come in to see me. And it's equally, I think, an issue of generational equity. When we think about how, generally speaking, the sentiment in our country right now is around how hope and opportunity is eroding because inequity is getting wider. That's why, we see this in birth outcomes. A mother today is 50% more likely to die. And I think that's part of what we need to attend to here too. So in my role at Maven, I oversee our clinical strategy, our clinical programming, our clinical operations. I think the key, I think, as I think about my own role and where digital health fits in, is that obviously there's no app that's going to fix racism. I think that's really important to name too. But what digital health can do is change who's centered in our system by connecting people to services based on what they need rather than what's physically proximate to them. So one of the things I'm very proud of at Maven is that we've invested in building the most diverse telehealth network in our space, which is diverse not just in terms of technical expertise and specialties, but 40% of our providers identify as BIPOC, 10% identify as LGBTQ, 30 languages are spoken. And what that means is when somebody is seeking out care, we can match them to a provider based on the expertise they need, as well as based on a shared lived experience. In 2021, 2022, there's no excuse in digital health for not speaking someone's primary language and not trying to meet them where they are. So I guess at 10,000 feet, that's my philosophy. That's sort of what we're up to at Maven. And I'm really looking forward to the discussion with my colleagues here from Babyscripts and Unite Us.
Thank you so much, Dr. Shah. We'll move on to Juan Pablo Segura, who is the co-founder and president of Babyscripts.
Hello, everyone. Will you be controlling the slides? I just want to make sure, or one of your colleagues.
Yep, I'm here.
All right, so I'll just say next slide then. So, again, on the heels of the Congresswoman and Dr. Shah, that this is an incredibly important conversation, and we're really on this call. I think the work that we do at Babyscripts, obviously, I'm a little biased, is very important, but we're really with some incredible change makers that can really change the trajectory that pregnant women, have been on over the last couple of decades to obviously bend the curve in the right direction, which is reducing maternal mortality and morbidity. So, we're really proud at Babyscripts to be a part of the conversation. And so I have a few slides here to just highlight what it is we do, but to circle some specific challenges that we see at Babyscripts and just introduction. My name is Juan Pablo Segura. I'm one of the founders of Babyscripts. And so if we go to the next slide, just kind of high-level introduction. We started Babyscripts, man, almost 7 years ago with really this idea that you didn't have to be in the clinic, in the four walls of the clinic to receive obstetrical care in the first place. And so 7 years ago, we partnered with a local provider. We're based in Washington, D.C., George Washington University Hospital. And we built a program that's now grown to more than 70 different health systems in 32 different states. We monitor and engage about 7% of the pregnancy population in the country. And we have some incredible partners that are bringing Babyscripts to really the patients that need these experiences the most. So whether it's groups like United, Medicaid, AmeriHealth, Caritas in multiple markets, a big focus of us is really bridging a lot of the disparities that exist in the country. Next slide. And so what we do, really kind of high level, I don't have a lot of time, but the Babyscripts program is a combination of a mobile app experience and what sits on top of our app that really makes us unique is what we do around asynchronous remote patient monitoring. And that's a very erudite technical term, but we really make it a point to highlight it because within the world of telemedicine and telehealth, there obviously are video visits, synchronous experiences, but we think with the massive provider shortage that exists in obstetrics, you have to start thinking about new and evolutionary ways of delivering technology where you don't have access to a person, even on another screen. And so really what we do with our remote patient monitoring is we automate several different points of delivering care through the Babyscripts experience. Next slide, please. And really the program, as delivered it's all delivered through providers. And so when you receive Babyscripts, you're being onboarded by your provider, again, across these 32 different states and kind of massive provider groups. And really what we focus on as a company is really addressing the access to care crisis that exists in obstetrics. So if you just look at the rural kind of map of the country, 50% of counties lack a practicing OBGYN. And so when you start thinking about, patients having to drive 3, 4, 5 hours to see their provider for 5 minutes, that creates massive problems. We really have an infrastructure problem in delivering better care to our pregnant patients. Next slide, please. And this isn't necessarily just a rural problem, and I think Dr. Shah really hit on this. We're based in DC, and we have more per capita doctors than most cities in the country. But if you live on the east side of the city, all of a sudden, your landscape and the options that you have as a patient, a pregnant patient, completely change. So you go to the next slide, please. So like I mentioned, if you live on the east side of the city, there is no L&D for you to go to. There is no maternal fetal medicine group for you to visit. And so when you start thinking about, okay, I need good prenatal care, Dr. Shah mentioned this, and so I'm glad we think the same way. You have to take 2 buses, 2 trains to just see your provider for 5 minutes. And if you look at where all the challenges are in outcomes in this patient population, it's in the Medicaid patient population. And so they're having to choose between working and getting paid and putting food on the table, or getting good care. And we think that that's unacceptable, which is why we built the Babyscripts experience, which is really focused on making care available at any time and at any place through this asynchronous experience. Next slide, please. So to really just kind of wrap up, I wanted to kind of take one specific challenge as we look at maternal morbidity and mortality and really blow it up. And so, we think that obviously trying to boil the ocean, there are so many challenges in improving the obstetrical landscape. I mean, we just talked about racism and these kind of systemic infrastructure challenges. But if you just look at, for example, some of the clinical conditions that exist, and if, for example, you can get an internet-connected blood pressure cuff into the home of almost every mom in this country, you can start to bend the maternal mortality trajectory almost immediately. And for like just focusing on something like preeclampsia and high blood pressure, that's something that we're specifically focused on. So if you go to the next slide, what we've done, for example, with our blood pressure remote patient monitoring is when a patient gets put on Babyscripts, they not only get our app, but if they're high risk or hypertensive, they'll get a kit in the mail that they can pair with our app. Babyscripts monitors their blood pressure in between appointments. And if anything is wrong, we alert the patient's provider in real time that there's an issue so that there can be an intervention. So if you go to the next slide, we've deployed this program across hundreds of clinics, hundreds of thousands of patients. We just did a presentation that I wanted to kind of showcase with the DC Maternal kind of Public Health Department. They had a focus on innovation. We highlighted what we did with the Babyscripts program and how we partnered with a local managed care company and providers to really make care available in the home at any point in time. And you can see the breakdown of who was enrolled on Babyscripts. These are all patients that are in maternal care deserts. And so they're now getting access to prenatal care through this kind of asynchronous remote patient monitoring experience. And if you go to the next slide, you can see that when patients take or are using Babyscripts and getting access to these technologies, all of a sudden, good things are happening. More interventions are happening. We call these things triggers, where we alert a provider that there's a problem with a patient's blood pressure. You can see the immediate benefit. 80 of these patients, AmeriHealth members that were put on Babyscripts that are on Medicaid, we are actually able to triage, whether it's life-threatening blood pressure, back to the provider within 5 minutes. And that's exactly the goal of what we're trying to accomplish at Babyscripts. So really the last slide here before I finish is, we have hundreds of interventions, hundreds of stories, happy to kind of go into them offline if you'd like to reach out to me directly. And then the last point and the last slide I have, I promise, is if we go to the next slide here, it's really the outcomes that we've been able to generate. I think we might have missed a slide, but regardless, we've published quite a bit on, for example, we've been able to accelerate the detection of preeclampsia by 13 days, reduce preterm delivery, and some C-section kind of incidence rates, across very large sample sizes in Medicaid environments. Again, when you start thinking differently about how can you deliver care, again, not necessarily always in the clinic, but at home. So thank you very much for your time, and hopefully I was able to share some good ideas with folks.
Well, thank you so much, Juan Pablo. That was excellent. I wrote down one thing you said here, meeting moms where they are means new and evolutionary ways of delivering care, and all the things you shared about Babyscripts demonstrates how that can deliver positive outcomes, right? Very, very impressive, the work that you all are doing. I'd like to invite Jackie Cornell, who is a senior director at Unite Us, to introduce herself and share a little bit about the work that she's been doing.
Thank you so much. This is such a great panel, and I'm so honored and excited to be a part of it. As was mentioned, I'm the Senior Director of Regulatory and Government Affairs at Unite Us, but I come to Unite Us with a background both in state and federal government, most recently as the Deputy Commissioner of Health in New Jersey, where maternal mortality was one of my marquee sort of huge issues that we were working on. And so there are often times when you are engaging in specific work and then months or years later, a solution comes along that you're like, if I had only known about this earlier. And in many ways, that's the story of how I got to be with Unite Us and the story of what we do. Unite Us was founded in 2013 as a company focused on using technology as well as people power to ensure that social determinants of care, of health are being met, and realizing that for so many individuals, the work that is happening to address their health outcomes is happening outside of the clinical walls. So what goes on all of those different factors, from housing, transportation, food, et cetera, that impact what goes on for that 20% that happens in the clinical setting. And so we started several years ago and have now expanded. We are operating in 42 different states around the country, and really drive at the creation of networks that bring together community-based organizations, health providers, government entities, and a variety of players to create networks that address the common needs of a community. And so what I thought I would do, Juan Pablo, we were only supposed to have 3 slides. So I was very good and I kept it down to 3. But I thought what I could do is walk you all through what a patient's journey in the Unite Us platform would look like as it relates to maternal care, and then also explain a bit more about what we do beyond our platform. Because for those of you who are sitting as program managers, as decision makers in local, state, county government, one of the biggest things that enticed me what beyond the platform itself was what we're able to do with that data. So this first slide here is a great one to show that story. So an expectant parent comes into an FQHC for a checkup and is assessed and screened, and it's determined that they have several needs that need to be met. And is probably no surprise to anyone here, transportation, food insecurity, and housing instability are our top 3 in almost every single community that we serve. They vary in rank across the country, but many of you know that this is true. We just talked about the bus routes. We know these examples. What happens is the referrals are put into our system. And then there is an electronic transfer that happens. So gone are the days where we're handing a patient a pamphlet and saying a prayer that they get the services that they need. Sue, who screens Sarah at the FQHC, is able to see that those referrals are resolved. And even more so, our team on the ground is making sure that those referrals get resolved. So if there's an instance where something is not being addressed, we have a team of people that are monitoring what's put into the system to make sure that those things are happening. And then we're able to ask the questions to the community-based partners. Well, are you at capacity? Is something going on? Like, why haven't these referrals been closed? Why haven't these services been met? And work to triage to make sure that there's a resolution for Sarah. What happens is that in real time, Sue and other providers at the FQHC are able to see what is happening in Sarah's file. So let's say the next time she comes in for her next visit, she sees a different clinician. That clinician is able to assess and look and understand these were the referrals that were made for Sarah. She went and she received them, and be able to ask Sarah about that experience. So it provides an opportunity to have a more robust and de-siloed continuum of care between the clinical interventions and the human services or social services side of the house. What we really do is try to drive at how can we make an individual's total health journey the most seamless for them and also the most beneficial for the system. How can we make sure that people are being seen effectively and efficiently and not being passed around and around and around again to different social service agencies because they can't, there's no availability, as heartbreakingly is often the case, right? You'll refer someone out, they won't get seen there because CBO is at capacity, and then the person's just left to figure it out on their own. We ensure that in those instances when there is capacity, we find and work to provide an opportunity to get that person the services that they need. I'll go to the next slide, please. So the platform is in many ways the foundational building block of what we do. But for me, what is probably the most exciting is the ability to move beyond what's happening in that interventions with patients and clients in communities, and actually be able to drill into, well, what is happening? What can we show? What can we articulate? Now, somebody who has spent most of their career trying to answer the how in solving problems, but never being able to put your hands around timely data. So looking at maternal health care issues, is it lack of transportation because there is no system to help them, or is the system being oversaturated, right? Is there food insecurity because they're in a true food desert and there's no social service agency around that family to provide, or is the food bank at capacity and maxed out? Being able to tell that in real time using our insights is one of the most, I think, rewarding opportunities for local government, program officers, researchers, because oftentimes the data that we typically see in government is 2, 3, 4 years old. And so being able to assess what's happening on the ground as it's literally playing out is I think incredibly important for how do you make those further up the stream determinations about where to put your resources. Another important thing that we do is we make sure that we create a network hub. So let's say the inverse happens. Instead of Sarah presenting at an FQHC and needing housing support, let's say an individual shows up at a shelter and is very clearly suffering from mental health, behavioral health, some issue that the shelter is not equipped necessarily to triage. Individuals have the ability to come into the network hub and say, look, I am experiencing somebody who needs some additional services. Help me figure out what to do, how to find the right place for them. And so our hub allows for sort of an escalated sort of triaging to navigate with the patient to make sure that they're getting the care that they need. And the third piece that I'll mention is our ability to pay for interventions that drive outcomes through our payment platform. So realizing that for so many small CBOs, that just navigating the payments process with either federal dollars or state dollars can be incredibly onerous. We walk that back out and address it so that they are allowed to do those engagements on our platform with virtually like a couple clicks of the mouse. What we're also driving to do is also from a payments perspective, try to push and have conversations with policymakers, given those earlier insights that I talked about, to say, hey, did you realize that in X county, transportation was the biggest issue facing, expectant parents? How are you planning to solve for this? Because I think, as most of us know, either anecdotally or through research, most expectant parents and most caregivers of young ones know that they should be at those postnatal visits, know that they should be doing those baby wellness visits. It's the hurdles that are in place that we want to address. And I think Dr. Shaw said earlier, no technology, no solution is going to solve for systemic racism, is going to solve for implicit bias. But what Unite Us, I think, really does an excellent job of doing is trying to peel back some of the hurdles that are there so we can meet the needs of people most directly. And then our policy team works to address how we see that data in systemic fashion to drive policymakers and budgetary appropriations folks to make better resource allocations to fill those gaps on the back end. The last piece is that we are fully interoperable. So in states like North Carolina, Virginia, we work hand in glove with state government and health systems to make sure that data is moving both securely but seamlessly throughout a patient's journey. And I'll go to the next slide, please. And then the last piece is really, we are anchored in communities, and we talk about our communities. We have staff on the ground who most of them are hired because they are from those places and know those communities well. The maternal health is going to look different in every single place that we operate because the needs are going to be different. But what we can do is to really understand that this is a longer trajectory. This is a longer path. As was mentioned, some of these adverse outcomes are happening in the 46 to 365 days post-birth. This isn't just the first 3 trimesters. This is the 4th trimester and the several years after that. So I'm realizing that I'm close to time. I want to keep on time, but I'm excited to be in this panel and discussing these issues with this group, and welcome feedback and thoughts as we continue. Thank you so much for having me, and thank you so much for doing this.
Thank you so much, Jackie. You could have, kept going. I was really enjoying your presentation. I think the work that you're doing is very important. You're looking at the entire ecosystem, but you're also drilling down to specific barriers, and you're looking at how to address individual health outcomes. And I think that's just fantastic. I see we have about 20 minutes left, and we have some time for Q&A. Just a reminder to our participants, please do go ahead and type your questions in the Q&A chat box, and I'll read them out to our panels. I'll go ahead and throw out the first question I saw out there. Somebody asked, English-speaking Black population here in the US has the worst healthcare outcomes, regardless of socioeconomic status or education. and the question goes, especially when you look at maternal mortality, right? And the question goes to all of our panelists, what are the broader implications for maternal health disparities through telehealth and remote patient monitoring and digital technology? How can we start to address some of this? I think, Jackie, maybe I'll ask you to go first because you kind of talked about this, and then maybe we'll go to Dr. Neil Shah, who also, talked about how racism is impacting our social determinants of health and how that impacts our health outcomes. So I'll throw it over to you first, Jackie.
Yeah, thank you. So I think for me, it's a lot of how do we start to answer those questions more meaningfully and thinking about what are the questions that we want to ask of the data early on. And so for me, I spend a lot of my time talking to policymakers and to folks at all levels of government, trying to see what do you think the problem is, and how can our data show you or point you in the direction to either validate that kind of solution that you think is going to work or not. I am frequently reminded how often well-intentioned policymakers approach an issue without actually spending time in the community that they're trying to solve for. And so thinking about, what kind of data do they want and do they need, but also what are they doing to engage the community? Have they had listening sessions? Have they had community forums? I know that the pandemic has zoomed us all out. We're all tired of being on Zoom, but there are still ways to solicit that kind of feedback. And so I would sort of put the question back on the group. It's like, it's going to look different everywhere, but I think starting with the right types of questions and engagement from government at a variety of places, a variety of levels, is one way to start the dynamic there.
Thank you, Jackie. Juan Pablo, I see your video is on. Do you want to answer that question too?
Well, I don't want to take screen time away from Dr. Shah, so I know he was second in line there, but I think this is obviously, so one of the challenges when you're a technologist is there's this massive push to standardize because of scale. And sorry if I'm going if I go way too much in the weeds of the visceral issues of a tech entrepreneur. But you're always thinking about how do I make this experience apply to 1 million patients, not one specific patient. And I actually think that kind of, I don't know if it's an investor mandate or kind of charge, but that actually directly affects and negatively impacts the patients that you yourself are trying to help in the first place, right? Because if you don't understand the cultural challenges and the racial challenges that exist in whatever community you're deploying your solution in, then you're really going to have a tough time not only making your solution effective in that environment, but really moving the needle in outcomes ultimately. And so for us, when we're partnering with providers, we have to embed ourselves in their workflow, and we have to customize our app to specifically address whether it's languages, kind of specific cultural resources, or regional kind of assets that are available in the community. A great example is what the work being done in Cradle Cincinnati, in the Cincinnati market, that has dramatically reduced the incidence of extreme preterm birth through a very kind of communal, kind of community-based kind of programming, specifically targeted to Black women. And so, for us, we really have to customize and address the challenges that our patients have at that level, at the regional level, at the communal level. And it directly impacts kind of your ability to scale. And you have to make a decision. Are you going to focus on, obviously really moving the needle on outcomes in that patient population? Or, are you going to make something kind of perfectly fit the investor kind of framework and archetype? And so there is that challenge in technology. It's not simple.
Thank you for that, Juan Pablo. Dr. Shah?
Yeah, sure. I mean, I think that digital health needs a point of view on how we fit in to not just the brick and mortar health system, but I want to touch on something that Jackie raised, which is, the community-based organizations, where there's this tension, and this sort of picks up on what you're saying too, Juan Pablo. I think there's an aspect of healthcare that's necessarily local, and for example, when we're talking about social determinants, community-based organizations are often the ones filling the gaps. And it's very important that they're of the community. When we're talking about maternal health, the whole energy that is responsible for maternal health being part of the national discourse, being platformed by the White House, are community birth workers. They're the ones who are bringing that. And so we need a way of thinking about how, as innovators in digital health, we fit alongside not only the brick and mortar healthcare system and sort of the traditional providers, but also the community. One of the things I'm particularly excited about is, being really thoughtful about where do you need a community worker who is necessarily of that community, and you're sort of dependent on that physical proximity, and when can you leverage the opportunity to not be dependent on that physical proximity. So for example, it may even, when there's somebody who's really struggling with breastfeeding, one of the things that I'm really proud of is we can connect them with a lactation consultant when they actually need one, like at 3 a.m. Within 27 minutes. And often, that birth worker, or certainly not the obstetrician or the lactation consultant, can be there physically. So I think that's one of the big opportunities for us as we think about how to address this at scale.
Thank you, Dr. Shah. I see we have a few more questions here, which is great. Always love questions. This one, I think maybe we'll throw to Juan Pablo, because you are our technology expert here. The question is around what types of technology. We're looking at apps and websites and portals and et cetera. What types really create the greatest level of engagement among low-income populations in particular?
Yeah, that's a tricky question because there isn't like a monolithic kind of channel that just works all the time. Actually, something that we've made publicly available is actually a playbook and how to engage kind of the hard to engage patient population. And so, I highly recommend, folks check that out, because we go pretty deep into that. I will say that, number one, there is, and I truly believe that this is very racist in and of it, like at its core, is there's this perception, for example, that Medicaid patients don't care about their health. And I like, first and foremost, we have to debunk that, because if you spend the time thinking through, not just workflow on a provider perspective, but the life flow of a patient and how they consume your solution, you actually spend the time doing that, you get not only above average, but you get incredible rates of engagement and compliance. And so, like for us, for example, we leverage, yes, push notifications, emails, text messages, but I think a very simple maybe example that I can share with you all around engagement and how to really take advantage of it is the whole bandwidth challenge that exists, right, for certain plans that a patient might have on Medicaid. So do they have a lot of data? Do they not have a lot of data? That's something we're constantly thinking about. And so, for example, when a provider enrolls a patient onto Babyscripts, the way we install the solution is we make sure that that patient is enrolled while they're still in the clinic. Why do we emphasize that? Number one, the patient can be connected to the clinic's Wi-Fi so that they don't have to use their data to be able to download the app, get through the first-time user experience, and to start using the program, whether it's monitoring blood pressure, blood sugars, maternal mental health challenges. And so you really have to think about the flow of deployment. And yes, I think you have to consider an all-the-above strategy: push, text, email, in-app. I mean, there's so many different kind of methods of engagement, but you really have to think about like the optimization at the beginning, because a lot of people miss out on that. They think, oh yeah, they can just find it on some app store and everything will be great. That's just not how these things work. So I think that's important to highlight.
Thank you for that, Juan Pablo. Our next question here, goes to something that Dr. Shaw mentioned earlier, which is the Build Back Better Act includes provisions from the Omnibus Act on maternal health, addressing maternal disparities in particular. And there's about $50 million, I believe, there that's been provided for growing and diversifying doulas in particular. So the question here is, is there any advice for health departments on how they can better address maternal health services like doulas, literacy training, provision of services in the BIPOC community, especially in rural and Native communities? These are usually very expensive and not really offered in those communities. So any advice from our panelists? And I don't know, Dr. Shah, if you want to start us off on this question. Thank you.
Yeah, so I think it's exciting to see, first of all, the commitment to doulas who, there's a Cochrane review, which is kind of like the gold standard for doing a meta-analysis in terms of data and research that shows that doulas are one of the very few evidence-based things that improve birth outcomes that we know of. There's also a study that shows that doulas are cost-effective. I think, Jackie, when you were in New Jersey, I think New Jersey was probably one of the first states to experiment with actually reimbursing doulas. Part of the challenge is that there's 1,000 different doula certifying organizations. So I think that state departments do have an important role from a regulatory perspective, and just thinking about sort of credentialing and that kind of thing. But fundamentally, I mean, we need to pay for what we want to see. And when you think about what every pregnant person deserves, it's careful monitoring, coaching, and support. Some also benefit from people like me who are surgeons, but most people don't. Yet we've designed the whole system backwards, right? Like most people, theoretically, from a reimbursement perspective, have access to a surgeon. But what they really need are the services that are provided by doulas. So I think, certainly the catalyzing funding from the Omnibus, which I hope will be included in the final provisions, will be helpful. But I think state departments have a really, really important role in thinking through how they can provide reimbursement, particularly for the Medicaid population, and how they can think about some of the, from a regulatory perspective, the certification system, so that people in the community know that they've got, well-trained and trustworthy partners there.
If I can add just one thing. Oh, sorry, Jackie, go for it.
I was just going to say, I think one of the hardest nuts to crack is this fine line between making sure that the states are regulating the doulas appropriately. But as Dr. Shaw mentioned, there's hundreds, if not thousands, of certifying entities for doulas. And so one of the things I think that would be helpful is trying to find some standards of what are core universal national standards. I say that though, and full well knowing that there's a really risky balance here to make sure that those standards are not so onerous that we're essentially asking doulas to be midwives and not realizing that the doula role is intrinsically and entirely different than that of a midwife. And that is, I think, one of the hardest things that we worked through in New Jersey is trying to find an equal sort of setting in terms of what is the core requirements of being a doula that didn't exclude individuals who had been practicing this work, sometimes for 2 decades. We were having doulas who were, supporting the second generation in a family, and making sure that those individuals with that depth of experience aren't kept out of whatever reimbursement program is created due to whatever the qualifying, regulatory structure makes up. And so it's not an easy task. It is, to find that sweet spot is something that I would encourage folks to spend a lot of time on. There was just news out of TRICARE, and I think the standards there might be doing just that, might be so steep that they're excluding many doulas from being brought into that program.
Yeah, I was just going to add, kind of taking it a little bit higher in terms of what public health departments can do, whether it's city public health departments, state public health departments. I think they play an incredibly crucial role in partnering with, whether it's innovative companies, nonprofits, to really promote the use of these new technologies and approaches to care. I mean, we partnered with the Mississippi Public Health Department Institute to essentially allow providers in high Medicaid environments in Mississippi to use Babyscripts for free. So there was no kind of starting cost to leveraging, our technology, our monitoring. And again, that was funneled and paid for through a public-private partnership. And these public health departments know all the resources in a community. They know all the providers. I mean, they really are crucial to organizing kind of these communities. And so I think that's an often ignored asset that can really be a huge kind of stimulus to change.
Thanks, Pablo. I see we have about 4 minutes left here on our panel.
I think we actually have to wrap up right now. We're 1:55 is time.
Panel at 2 o'clock coming right behind us. So we'll move to just our closing remarks on this last question.
It was 1:55.
What's the future of digital health and maternal care? What is
I can't hear her. I don't know if others can, but
Oh, I'm so sorry. I moved my microphone. Okay, can you hear me now?
Yes.
Okay, perfect. Sorry about that. Yeah, so we'll move to closing remarks given the time. So I just wanted to ask the panel this one last question in your closing remarks. What is the future of digital health and maternal care, and what does health equity look like? Jackie, can you kick us off with that?
What does health equity look like? To me, the easiest answer is every person in this country being able to have the birth that they want and the outcomes that they want in a healthy, safe, and happy environment. That's health equity.
Thank you, Jackie. Juan Pablo?
yeah, I think it's just core to being able to access healthcare when you need it at any time and at any place. And we have to get beyond this concept that everything has to happen knee to knee, in a sterilized, kind of waiting room or clinic. I think that needs to start to evolve a lot more.
Thank you, Juan Pablo. Dr. Shah?
I think in the context of this conversation, it's being trustworthy, because it's not the job of the people that we're serving to be more trusting. It's our job as people who are trying to innovate in healthcare to be more trustworthy. So that means showing up for people when they expect us to, meeting them where they are, and then ultimately, affirming them along the way, listening to them, hearing them, and producing the outcomes that they deserve.
Thank you, Dr. Shah. And I echo everything that's been said by our panel. I think from my perspective, health equity looks like, as you said, Dr. Shah, meeting people where they are. It looks like individual care. It looks like strengthening our ecosystem, making healthcare more sustainable, more accessible. So I thank you all, our panelists, for this conversation. I thank all of our participants who attended. We were asked to share with you that the next panel will be Venture Capital and Health Equity, Exploring Trends in Digital Health Investments.
I was just going to say, we actually have simultaneous panels coming up at 2, so participants can choose and click into whatever session they would like.
Okay, fantastic. And you can go to the Whova, is that the Whova platform, to make your selection. So thank you again for participating in the EHI Health Equity Summit. And we've enjoyed this conversation and hope you enjoy the rest of the summit. Thank you.